It's now 17 minutes after the hour, and we will now reconvene the meeting and move on to the next session for the afternoon. I believe Dr. Jefferson Jones is up first, and he will begin our session with a presentation on SARS-CoV-2 epidemiology in children. So Dr. Jones, the floor is yours.
Good afternoon. In this next slide, please. In this presentation, I'm going to give an overview of the epidemiology of COVID-19 in children aged 5 to 11 years, covering incidence and seroprevalence estimates, COVID-19 associated hospitalization rates and mortality, multi-system inflammatory syndrome in children, MISC, and additional post-COVID conditions. Finally, I'll briefly talk about transmission. Next slide. First, incidence and seroprevalence. Next slide. As of October 22nd, there have been over 45 million cases of COVID-19 reported in the U.S. The majority of these have been in adults, as of most hospitalizations and deaths due to COVID-19 illness. However, children have been greatly impacted by the pandemic. Here are the reported cases by age group, with children aged 5 to 11 years in dark blue. In total, there have been over 1.9 million cases of COVID-19 reported among children aged 5 to 11 years. Starting in July and August of this year, there was a sharp increase in cases in this age group. Next slide, please. Over the past few months, we are seeing children aged 5 to 11 years, shown in dark blue near the bottom of the figure, making up a greater proportion of total cases, representing 10.6% of all cases reported to CDC in the week of October 10th, 2021, while making up 8.7% of the total U.S. population in the 2020 census. Next slide. Data shown on the previous two slides were for cases reported to CDC. However, many infections are asymptomatic or result in mild illness and are not tested and reported. To estimate all infections, CDC conducts an ongoing nationwide seroprevalence study in collaboration with commercial laboratories. A screenshot of the CDC data tracker seroprevalence webpage is shown on the right. Every 2 weeks, approximately 50,000 de-identified serum specimens are collected by commercial laboratories for preventive or acute clinical care and are tested for SARS-CoV-2 antibodies. However, many jurisdictions have limited availability of pediatric specimens. People presenting for acute or clinical care or screening and having their blood drawn by commercial laboratories might not represent the general population, particularly in children who do not frequently require blood tests. The most common reasons for the clinical visits, as documented by ICD-10 codes among children, include general examination, which could include cholesterol, as all children are recommended to have cholesterol screened between ages 9 to 11 years, obesity, long-term drug monitoring, and fatigue. Next slide, please. Displayed are the weighted infection-induced antibody seroprevalence estimates by age group for September 2021 for 47 U.S. jurisdictions. These results are preliminary and are subject to change. Seroprevalence in children aged 5 to 11 years is estimated to be 38%, which is higher than seroprevalence estimates among adults and similar to estimates in children aged 12 to 17 years. Seroprevalence varies greatly by state and jurisdiction. Among 23 jurisdictions with at least 75 specimens collected from this age group during September, the state or jurisdiction level estimates ranged from 11% to 61%. And this seroprevalent estimate is different than the estimates presented at the FDA VRBPAC meeting. It includes 47 jurisdictions for September, as opposed to 15 jurisdictions for May to June. Using seroprevalence to estimate the cumulative number of infections, the number of infections per reported cases by age was calculated. For the general population, including adults, the jurisdiction level infection to case ratio was a median of 2.4 with a range of 2.0 to 3.9. For children, the infection to case ratio was substantially higher, with a median of 6.2 and a range of 4.7 to 8.9. Next slide. Numerous children aged 5 to 11 years have been previously infected, but what does this mean for vaccination? Based on data in adults, infected individuals have a low risk of infection for at least 6 months, but protection is not 100% and is likely lower against the Delta variant. Of note, the antibody response after infection is lower and less consistent, meaning there is a wide range of antibody titers in response to infection, compared with mRNA vaccine-induced antibody response, which produces higher and more consistent antibody titers. Additionally, antibody titers generated after infection are lower in people with mild or no symptoms. Infections resulting in mild or no symptoms appear to be much more common in children with SARS-CoV-2 infection than in adults. Data among children are lacking, and data in adults might not apply to children. Substantial immunologic evidence and a growing body of epidemiologic evidence indicate that vaccination after infection significantly enhances protection and further reduces risk of reinfection. Among those eligible, CDC recommends vaccination regardless of a history of infection, and serologic testing to assess for prior infection is not recommended for the purpose of vaccine decision-making. Next slide. Seroprevalence data suggests infection in children are less likely to be reported compared with adults. Seroprevalence estimates in children aged 5 to 11 were approximately 38% in September 2021. Seroprevalence indicates that children are at least as likely as adults to be infected with SARS-CoV-2. Note that residual serospecimens collected by commercial laboratories, again, may not be representative of the general pediatric population. Antibody tests cannot determine if a person is protected from infection or not. The assay used for the analysis, a total antibody test that maintains high sensitivity for at least 6 months after infection, is good for detecting previous infection, but unlikely to correlate with protection from infection. Next slide. Next, hospitalization. Next slide. I'm now going to review pediatric hospitalization data from the COVID-19 Associated Hospitalization Surveillance Network, or Cobinet, a population-based surveillance system that collects data on laboratory-confirmed COVID-19 associated hospitalizations among children and adults through a network of over 250 acute care hospitals in 14 states. Data are preliminary and subject to change. Cases are identified in Cobinet if they test positive for SARS-CoV-2 through a test ordered by a healthcare provider and are hospitalized within 14 days of the positive test. This chart illustrates weekly rates of COVID-19 associated hospitalizations by age group, with children aged 5 to 11 years in red. The cumulative hospitalization rate was 32.3 per 100,000 population for this age group as of October 23rd. As you can see, rates for this age group have been consistently lower than other age groups. Note, however, that in September 2021, for children aged 5 to 11 years, population-based hospitalization rates were higher than in any other previous point during the pandemic. Next slide. Variations in hospitalization rates by race and ethnicity are seen, with American Indian and Alaska Native, Hispanic, and non-Hispanic Black children having cumulative hospitalization rates that were 3 times as high as the hospitalization rates in non-Hispanic White or non-Hispanic Asian children. This disparate impact of the pandemic, including higher rates of hospitalizations on these groups, is similar to disparities seen in other age groups. Next slide. To further put the burden of COVID-19 illness in context, we compared COVID-19 and influenza-associated hospitalization rates among children aged 5 to 11 years using data from Covinet and data from the Influenza Hospitalization Surveillance Network, or FluSurvNet. FluSurvNet, a long-standing platform that was leveraged to create Covinet, conducts population-based surveillance from October 1st to April 30th each year, which is roughly MMWR weeks 40 to 18 as shown on the x-axis of the displayed figure. This time frame is the typical U.S. influenza season. Influenza-associated hospitalizations occur seasonally, with very low influenza detection during May to September, which is shaded in the gray in the figure, suggesting that few influenza-associated hospitalizations are missed during that gray area that is outside the October to April surveillance window. Therefore, FluSurvNet rates from October to April were used to approximate the annual influenza hospitalization rate. FluSurvNet has a similar catchment area to that of Covinet and uses similar methods for case ascertainment and data abstraction. So displayed in blue, green, and red are the rates of influenza-associated hospitalizations from October to April during the 2017 to 18, 18 to 19, and 19 to 20 seasons. For ease of comparison, influenza-associated hospitalization rates were extended out in a dashed line. Next slide. Here, the influenza 2020 to 21 rate is added and displayed in black. It was extremely low, with only 9 hospitalizations being reported across all pediatric age groups. This is likely because during this season, mitigation measures such as school closures and mask wearing were in place, decreasing influenza transmission. Next slide. During this same time frame, here the COVID-19 associated hospitalization rate is added, shown in yellow. It was calculated for a 1-year period, October 1st to September 30th, 2021, because COVID-19 transmission has been occurring throughout the year. The 2020 to 21 annual COVID-19 associated hospitalization rate, in yellow, was similar to influenza associated hospitalization rates for the 2017 to 18 and 18 to 19 seasons, shown in blue and green. And the COVID-19 rate was lower than the rate for the 2019 to 2020 season for influenza, shown in red. The low influenza hospitalization rate for the 2020 to 21 season, shown in black, suggests that the annual rate of COVID-19 hospitalizations might have been much higher, including higher than influenza hospitalization rates, during typical influenza seasons, had these COVID-19 mitigation measures not been in place. Next slide. To compare outcomes and interventions in children hospitalized with COVID-19 with another disease, we compared with influenza, combining 3 pre-pandemic influenza seasons from 2017 to 2020. The median length of stay among children hospitalized with influenza was 2 days versus 3 days for children with COVID-19. 21% of children with influenza versus 32% of children with COVID-19 required ICU admission. 4.6% of children with influenza versus 7.2% of children with COVID-19 required invasive mechanical ventilation. And a similar proportion of children with influenza versus COVID-19 died in the hospital, approximately 0.6%. Next slide. Of 562 children aged 5 to 11 years who were hospitalized with COVID-19 during March 2020 to August 2021, 68% of children were Hispanic or non-Hispanic Black, which make up 1/3 of the general population. 32% of hospitalized children had no underlying conditions, and the most common underlying conditions were chronic lung disease, primarily asthma, and obesity. Next slide. Next, I'll discuss COVID-19 associated mortality in children aged 5 to 11 years. Next slide. As of October 22nd, there have been over 730,000 COVID-19 deaths reported in the United States, the vast majority in adults. However, deaths in children have been reported. Displayed are counts of reported COVID-19 deaths by age. Between January 1st, 2020 and October 16th, 2021, there were 94 COVID-19 deaths reported among children aged 5 to 11 years. Among deaths in this age group, COVID-19 associated deaths account for 1.7% of all deaths during the same time period. And please note there is a lag in death reporting. Next slide. To put this into context, this table displays the top 10 causes of death for children aged 5 to 11 years for the year 2019, the most recent year with complete NCHS mortality data. Restricting to the 12-month period of October 3rd, 2020 to October 2nd, 2021, a 12-month period, there were 66 COVID-19 associated deaths reported for this age group. This would be equal to the 8th leading cause of death for 2019. In contrast to COVID-19, during the 2020 to 21 flu season, only 1 death in all age groups for children from influenza was reported, likely because of reduced transmission due to COVID-19 mitigation measures. As displayed in the table, during 2019, 84 influenza pneumonia-associated deaths occurred among kids aged 5 to 11 years, the 7th most common cause of death. This suggests, similar to COVID-19 hospitalizations, more COVID-19 associated deaths would likely have occurred had these mitigation measures not been implemented. Next slide. I will now discuss multisystem inflammatory syndrome in children, or MISC, followed by additional post-COVID conditions. Next slide. MISC is a severe hyperinflammatory syndrome, typically occurring 2 to 6 weeks after acute SARS-CoV-2 infection, resulting in a wide range of clinical manifestations and complications. Incidence has been estimated as 1 MISC case in approximately 3,200 SARS-CoV-2 infections and varies with race, ethnicity, age, and region. Approximately 60 to 70% of patients with MISC are admitted to intensive care and 1 to 2% die. Next slide. Nationally, 5,217 MISC cases have been reported. Children aged 5 to 11 years are the age group most frequently affected by MISC. The median age of cases is 9 years, and 44% of all reported MISC cases have occurred in children in this age group. A disproportionate 61% of children with MISC are Hispanic or Latino or non-Hispanic Black. And again, these populations comprise only 1/3 of the overall population of persons aged 0 to 20 years. Among children aged 5 to 11 years, 9 MISC-associated deaths have been reported, which is 20% of all MISC deaths. Next slide. Beyond MISC, additional post-COVID conditions occur in children. These encompass a wide range of new, returning, or ongoing health problems, including physical and mental health consequences, experienced by patients 4 or more weeks after initial infection with SARS-CoV-2. Few data on post-COVID conditions in children exist. It appears that post-COVID conditions in children is less common than among adults. In published reports, frequencies of occurrence have varied depending on the characteristics of the children studied and other factors. Further investigation is needed to better characterize post-COVID conditions in children. However, a national survey in the United Kingdom found that 7 to 8% of children with COVID-19 reported continued symptoms greater than 12 weeks after their initial diagnosis. Post-COVID conditions in children may appear after mild or severe infections or after MISC. Symptoms are similar to those seen in adults and include fatigue, cough, muscle and joint pain, headache, insomnia, and trouble concentrating. Next slide. Lastly, I'll review SARS-CoV-2 transmission among children. Next slide. Multiple factors impact the transmission of SARS-CoV-2 virus, including presence and type of symptoms of the index case, type and timing of the exposure, viral load, and variant. Some studies have reported similar rates of transmission from infected children as from infected adults, while others have found lower rates of transmission from infected children compared with rates from infected adults. Some data are from earlier studies that likely underestimated infections in children. However, it is clear that secondary transmission from children, both to other children and to adults, can and does occur, and has been reported in both household and school settings. Studies have shown vaccination decreases transmission. Next slide. Multiple household studies, outbreak, and contact tracing investigations have demonstrated efficient transmission among children and adults in multiple settings. Displayed is a recent MMWR article describing Delta variant transmission within a classroom setting in an elementary school, with an attack rate of 50% among students too young to be vaccinated. You can see from the figure on the right that some students, in dark blue, were links in transmission to other students, to siblings in light blue, and to their parents, shown by circles with the diagonal stripes. Next slide. In summary, children aged 5 to 11 years are at least as likely to be infected with SARS-CoV-2 as adults. Over 1.9 million reported cases have been reported, and seroprevalence is estimated to be approximately 38% for September 2021 using the data set previously described. Seroprevalence data suggests that infections in children are less likely to be reported as cases than infection in adults. Children aged 5 to 11 years are at risk of severe illness from COVID-19. Over 8,300 hospitalizations have occurred to date. Hospitalization rates are 3 times higher for non-Hispanic Black, non-Hispanic American Indian and Alaska Native, and Hispanic children compared with non-Hispanic white children. Hospitalization rates are similar to pre-pandemic influenza-associated hospitalization rates. Severity was comparable among children hospitalized with influenza and COVID-19. Approximately 1/3 of hospitalized children aged 5 to 11 years require ICU admission. At least 94 COVID-19 associated deaths occurred in children aged 5 to 11 years. MISC was most frequent among children aged 5 to 11 years. post-COVID conditions have been reported in children. All of these adverse outcomes would likely have been more numerous had pandemic mitigation measures not been implemented. Finally, secondary transmission from school-aged children occurs in household and school settings. Next slide. Thank you to the numerous people who contributed to the data presented today.
Thank you, Dr. Jones, for that excellent presentation. This presentation is now open for questions. Thank you, Dr. Paling.
Thank you, Dr. Jones, for this great presentation. It's very clear and demonstrates the illnesses and the epidemiology of COVID in children 5 to 11. One of the questions that I have is we talk a lot about MISC. And do we have any data on MISC in children 12 to 17 and any data on how that frequency has changed since vaccine has been approved for children 12 to 17? Thank you.
I know I have some MISC experts on the line, and I'll defer to them. Thank you.
Hi, can you hear me? This is Angie Campbell.
Yes, we can. Thank you.
Okay. Hi, Dr. Paling. We don't have that data yet. We are hopeful that a couple things, I guess. There's such a lag to our MISC National Surveillance System reporting that the cases were really quite low through the summer. And now that vaccination has become more common in the 12-year-old and over group, maybe that will make a difference with what we see in the current wave of cases that are being reported to us, but we just don't have that yet. And then the other piece that we hope to have in a few weeks when we get enough cases is we do hope to look specifically at vaccine effectiveness against MISC in hospitalized children, but we don't have those numbers yet either.
Thank you. Dr. Daly?
Yeah, thanks so much. I have a comment and then a question. A comment is that it's around severity. As a general practicing pediatrician, if I see a child with COVID who I admit to the hospital, if I come back to work the next day and hear that child's been admitted to the ICU, that's very concerning. It's not just a change in room number. It's an indication to me that illness for that child I just saw a couple of days ago is potentially life-threatening. And it looks like, based on these numbers at least, that the severity is at least as great as influenza or perhaps more. And then my question is around the seroprevalence. And thank you for describing that so clearly. It seems to me that those who get blood drawn may be different than those children who do not get blood drawn. And for example, if a reason for getting blood drawn is fatigue, which I think you mentioned, then that would suggest to me that it could have been a asymptomatic case of COVID that led to that blood draw. And so I would think that it's more likely that it would be an overestimate of the seroprevalence in the general population. But I wanted to ask you if that interpretation is reasonable.
Thanks for the question. The seroprevalence, as you mentioned, it comes from a unique group of children who are having their blood drawn. If anyone is specifically having blood drawn for COVID-19, then those serum specimens are excluded from the study. But as you mentioned, there may be other reasons, and an ICD-10 code for COVID-19 was not mentioned. So it is possible. Unfortunately, there are not many randomized household-based studies to compare to. These results are somewhat similar to other seroprevalence studies that have been in children, but most of those studies were using a very similar approach that are taking a convenient sample from laboratory sampled children. So your thinking is reasonable, and we don't have a great way to confirm it. Thank you.
Thank you. Ms. Bata.
Thank you for this presentation. Kind of in the same vein of seroprevalence, When you describe the number of sections per reported case, how do you determine that? How is that determined?
Can I clarify? This is the infection to case ratio.
Yeah.
So we did a particular study that was narrowed to, I believe, 6 or 7 jurisdictions. And for just in those jurisdictions that had complete age data, which we defined as greater than 90%, we compared the cumulative number of reported cases in children to the projected number of cumulative infections in children using the seroprevalence data. So if 5% of the population had been reported as a case and 20% would be projected to be infected per seroprevalence, then that would be a 4-to-1 ratio.
Thank you.
Thank you. Dr. Sanchez?
Thank you. No, it's very helpful data as we evaluate the vaccination strategies, Dr. Jones. But my question is, in the analysis of the hospitalizations and certainly mortality, did you take into account or exclude those patients, those children who were just tested for being hospitalized but did not have, who may have just been may have been asymptomatic from a COVID infection, but a lot of hospitals now, especially children's hospitals, we're screening on admission irrespective of what they may be having for any.
Dr. Jones will respond. Thank you.
All right. So the question is whether children in Cobinet had an infection that, say, due to they had a trauma and then tested positive for COVID-19 as opposed to being hospitalized for COVID-19. The COVID-19 team looked through medical records for all children, and if I remember correctly, it was 79% of children were confirmed to be hospitalized for COVID-19, with other cases being somewhat more difficult to determine. And I do not believe they were excluded from the analysis. If anyone else from the MISC team wants to add anything, they can.
Hi, this is Shika Garg. I can also comment on that, and that's correct, what Dr. Jones said. So among the 5 to 11 year age group, about 80%, 79 to 80% of those children were specifically admitted related to COVID-19 related illness. We've also looked at symptom data to look at it in a couple of different ways. And among children 5 to 11, about 87% had any one of the symptoms that we collect data on. And also that is correct that these people were not excluded from either the rates or from the table that was comparing severity among those with COVID versus those with flu.
Thank you. Dr. Paling.
Yes. When we looked at the hospitalization rate, it was clear that Black, Hispanic, and American Indian and Alaskan Natives had threefold higher rate of hospitalization than non-Hispanic white. When you look at the COVID-19 deaths, which are fortunately uncommon in children, do we see disparities in there as well? Thank you.
I do not know of an analysis of COVID-19 deaths by race and ethnicity that's available at this time. If anyone else on the phone knows of it, they can mention it. But that's something certainly that we will look at and would be expected, since both infections, hospitalizations, MISC have all followed similar patterns, and that's happened in adults, and deaths in adults follow similar patterns to that we would expect that to be the same in children.
Okay, thank you. Are there any additional questions that folks have on the phone?
Dr. Lee, this is Veronica McNally. May I ask a question?
Of course. Ms. McNally, please go ahead.
Dr. Jones, do you happen to know what percentage of children in this age group are considered to be obese?
According to the 2019 data, I believe it was 20.2% in this age group. There has been recent study out of Southern California that showed there was a significant increase in obesity during the pandemic. So it could have increased.
Thank you.
Thank you. While I'm waiting to see if there's any additional questions, I just wanted to remark on the stark disparities that continue to exist, and it's being highlighted in the pediatric population as well in terms of severe disease and hospitalization. And I think we recognize that those disparities in health that occur are, a consequence of decades of compounding inequities that impact both health and education of these kids. So just to say that I think there is much that we need to do to actually, not only through our recommendations, but through implementation, really continue to address those disparities. I'm just sad that this far in the pandemic, we continue to see that data that looks like there's such differences in the outcomes for kids and adults. And I see Dr. Campbell has raised her hand. Did you wish to respond to a prior question?
I did, thank you. I just wanted to address the death question. I can address it specifically for deaths associated with MIS-C. We published a paper, it was led by Anna Bowen in OFID, and we did actually see increased odds ratios in Black non-Hispanics and Hispanics relative to whites. And we didn't have large enough numbers to do adjusted analyses for AIAN and Native Hawaiian Pacific Islanders, but the crude ratios for those were very elevated relative to the white population as well.
Thank you. I see no further hands raised, so I think we'll move on to the next presentation, which is Dr. Matt Oster, who will be providing the committee with information on vaccine-associated myocarditis. Dr. Oster?
Great, thank you very much. And thank you for inviting me to speak on mRNA COVID-19 vaccine-associated myocarditis. I spoke a little bit about this last week at FDA, but I have some updated information to present as well today. Next slide. So today I'm going to be talking about some cases of myocarditis after COVID-19 vaccination, primarily in adolescents and young adults. We'll be talking about comparing the different types of myocarditis, and then some early information on some of the 3 to 6 month outcomes of myocarditis. Next slide. So first, I wanted to remind people of the updated numbers as reported to VAERS. These are reporting rates per 1 million doses administered of myocarditis after mRNA COVID-19 vaccines, looking at a 7-day risk period. In the interest of time, I'm just going to show the Pfizer data today, since that is the topic for discussion today. And this is looking at all ages for Pfizer, broken down by age group and males and females. As you can see, the reporting rates of myocarditis within 7 days after vaccination exceeded the background incidence for males after the first dose in ages 12 to 24, and after the second dose in ages 12 to 49, with a peak in that adolescence and young adulthood area. Amongst females, we did not see an increased risk or reporting rates after dose 1, but we did see a slight increase in risk after dose 2 in females ages 12 to 24, again with a peak in that 16 to 17 year range. Next slide. So those cases reported to VAERS, further investigation was performed to get more clinical information and to verify cases. 877 were able to be adjudicated as meeting case definition. A number still were under review and needed more information. Of those 877, 829 were known to have been hospitalized, with at the time of their report, 789 discharged. Now, of those, it was reported that they had recovered from their symptoms at the time of the report, with about a quarter of them having ongoing symptoms at that time of their report. A small number were not hospitalized. A proportion of them did get MRIs, so about 312 of those 877. Of those, the cardiac MRI was abnormal in 72% of cases, 223 of them. Next slide. I did want to take a moment to address the question of deaths that have been reported to VAERS with concern for myocarditis. This is the reports of deaths in persons aged less than 30 years among about 86 million doses from about 47 million individuals. When CDC receives reports of deaths, primarily through VAERS or through other means, a very extensive process is undertaken. This includes reading in reports that are sent to us, reaching out to the reporter to get more information, trying to obtain extensive medical records and autopsy reports if they're available, just having discussions and meetings with the state health departments, as well as with the medical examiner, and then whenever possible, offering to review pathology samples at CDC to look for, to answer any questions that may be pertaining to the case in terms of diagnosis or potential causes. We are aware of 9 cases where there was concern for myocarditis raised in death. There was one case where fully that information was not available. This is a case that has been published in the literature. It's a 27-year-old trisomy 21. This is available online. This individual did not have an MRI done, so we could not see if this is a confirmed myocarditis case. It was reported as fulminant myocarditis, and an autopsy was not available. The full investigation to look for other potential causes was not able to be undertaken. But 8 did have information available. Of these, 2 have an evaluation ongoing. 6 have their evaluation that has been complete. And these 6 have fallen into 2 categories. 3 were found to have myocarditis. 3 were found not to have myocarditis on review of pathology samples. These are thought to be other causes, cardiac causes of sudden death, which were not due to myocarditis, and with no evidence of that. Certainly there's a background rate of that as well. For those cases with myocarditis, further investigation was completed looking for other potential infectious causes. As I'll talk in a couple of slides, with classic myocarditis, there are a number of different infectious causes, both bacterial and viral, as well as some other causes that can lead to myocarditis. And in these 3 cases of myocarditis, a potential infectious cause was identified in each of those. And that leaves us with no cases thus far that have undergone full evaluation, in which no other potential cause has been identified. Next slide. Now I'm going to talk a little bit about the different types of myocarditis. We use this term a lot, myocarditis, and technically it means it's inflammation of the heart muscle. But there appear to be different varieties of myocarditis that can differ in the way that they present, the way they're treated, what their short-term outcomes are, and what their long-term outcomes are. Certainly we have classic myocarditis, and that's for lack of a better term. When I use that term, I really mean myocarditis in the pre-COVID era. And with the COVID era, we've now seen 3 different types of myocarditis. So myocarditis related to COVID-19 with the active infection itself, myocarditis related to MIS-C, myocarditis, and then COVID-19 vaccine-related myocarditis. Next slide. So classic myocarditis, or myocarditis in the pre-COVID era, as I mentioned, can have a number of different etiologies, particularly infectious etiologies. This is a partial list of common, viral, parasitic, bacterial, fungal, and protozoal agents that can cause myocarditis. And there are a number of non-infectious etiologies as well. Next slide. So the epidemiology of this myocarditis in children, annual incidence is about 0.8 per 100,000 per year, but it does peak as well in adolescents, about 15 to 18 per year. You can see in that graph on the left, there's an early peak before age 1, thought to be primarily related to some genetic causes, but then it rises again in adolescence. About 66% of cases are male, and there can be some significant morbidity and mortality in myocarditis, especially in the pre-COVID era. In adults, similarly, in this study from Quito et al., we see the peak in adolescence and young adulthood, especially amongst males. And the percent of males over time generally decreased. For females, it was pretty static over time with maybe a slight peak in the 50s and 60s. Next slide. For MISC myocarditis, on the left, you'll see in this paper published earlier this year about the first 1,700 cases of myocarditis. First 1,700 cases of MIC that were reported to CDC. Myocarditis was listed on the case report form in 17% of cases, about 300 cases. On the right, you see some data from Cobinet, which shows that there's more than just myocarditis. It's more than just myocarditis that pertains to heart involvement in MIC, where 80% of the first reported cases of MIC had some sort of cardiovascular involvement, with 50% have elevated troponin, 73% elevated BNP, and about just under 40% having decreased ejection fraction. Next slide. What about COVID-19 myocarditis? There have been some reports and concerns of this. This seems to be a problem more in adults than in children, myocarditis due to COVID-19. This is some data showing, from some large healthcare systems or healthcare aggregate data from EPIC and from Children's Hospital Association's FIS database. And the myocarditis that we see in pediatric patients is really mostly due to MISC. This is at least for the clinical myocarditis. There could be subclinical myocarditis that would not be captured by clinical databases, of course. Next slide. So how do these types of myocarditis, compare? So this study that is published online at medRxiv, and I did supervise one of our fellows at my clinical institution in this project. She looked at comparison of MIC-related myocarditis, classic viral myocarditis, and COVID-19 vaccine-related myocarditis. Did not include COVID-19 myocarditis because we had hardly any cases that we would call that. Next slide. What we found is that at least on presentation, cases of vaccine-related myocarditis looked very similar to the classic myocarditis or pre-COVID myocarditis. This slide shows the laboratory evaluations at presentation. You can see for troponin, BNP, lymphocytes, white blood cells, C-reactive protein, and platelets, the vaccine-related myocarditis group looked very much closely to the classic myocarditis group. Next slide. But when we looked at their cardiac function as measured by ejection fraction by echocardiogram, we saw a little bit of a different picture. On initial presentation, as you see there on the left, the blue group, the classic myocarditis group, and the red group, the MIC myocarditis group, about 2/3 of them had a decrease in their ejection fraction. So just over 30% had normal ejection fraction at presentation. Whereas in the vaccine-related myocarditis group, 7 of the 9 had a normal ejection fraction at presentation. For the classic myocarditis group, again the blue group, it took a while for a number of them to reach normal function, with about 1/3 of them not reaching normal function by 2 weeks. Contrast that with the MIC myocarditis group, where almost all of them regained normal function by 10 days after presentation. And then the vaccine-related myocarditis group, all of them regained normal function. The 2 that had decreased function, both regained normal function within a couple of days. Next slide. Well, what about the long-term outcomes? So that's the short-term acute outcomes. What do we know about long-term outcomes? This study published earlier this year looked at the outcomes in pre-COVID myocarditis and what are different risk factors that can be associated with a long-term outcome. Next slide. And they broke different variables down into what would be, what characteristics of that variable would be associated with a good outcome versus those would be concerning for a poor outcome. So I put in this yellow box here those variables which are similar with the pre-COVID myocarditis group and the vaccine-related myocarditis group. Like the pre-COVID myocarditis group, or the classic myocarditis group, Those with vaccine-related myocarditis tend to have chest pain at clinical presentation with little to no heart failure symptoms. That's the New York Heart Association classes. Their electrocardiograms tend to, if they show abnormalities, will show ST elevation. For biomarkers, their troponin can certainly be elevated, as shown on the earlier slide, but they tend to have a fast decline. Echocardiogram, many will have preserved ejection fraction at the onset, but if it is decreased, we tend to see early improvement or normalization of that. Next slide. One variable associated with poor outcomes, though, that we also see in those with vaccine-related myocarditis, compared to the classic myocarditis, is the cardiac magnetic resonance imaging findings. I showed earlier, 72% of those who had an MRI had some sort of abnormalities, often with presence of late gadolinium enhancement. What exactly this means for this particular group, though, still remains to be seen. Next slide. And it's because of the pre-COVID, the classic myocarditis group, and some of those long-term outcomes, with the concern really being sudden cardiac events, that the American Heart Association and American College of Cardiology have these guidelines that were put in place in 2015. And they recommended that after someone is diagnosed with myocarditis, that before they return to competitive sports, they should undergo extensive cardiac testing, including echocardiogram, rhythm monitoring, and EKG. Though it's unresolved as to whether resolution of LGE, that's late gadolinium enhancement, should be required. Importantly, the recommendation at the time was independent of age, gender, and function. So for lack of data in the current era, since we're still learning about vaccine-related myocarditis, these guidelines have often been applied to those with vaccine-related myocarditis as well. Next slide. So what are we seeing, though, in the 3-month outcomes, at least? This is data from Vaccine Safety Data Link. This includes a large network of health systems and looking at electronic health records. This data comes from just looking at chart reviews, so looking at visits that people may have had. And in the for those who are considered recovered, now on no medications, without any sort of exercise restrictions or symptoms, that was the case in about 30% of 12 to 17-year-olds, about 40 to 50% of those 18 to 39. About a quarter to a third of cases were still symptomatic, listed on their chart. And a number were still on medications, the older groups more likely than the younger groups. Although the younger groups, the 12 to 17-year-olds, were more likely to still be on exercise and physical activity restrictions. Next slide. But beyond just looking at the chart, CDC has launched an investigation to look at long-term effects of myocarditis. This involves 2 parts. Number 1, calling the patients or the parents of the patients that have been reported to VAERS. And then number 2, asking them to identify a healthcare provider, usually a cardiologist, that they have been following up with to identify more detailed clinical information. Next slide. CDC has been able to reach just under 250 patients thus far, and have asked for a self-report of whether they had any of these symptoms within 2 weeks, the prior 2 weeks of the phone call, and the phone calls were about 3 months after their initial myocarditis diagnosis. And for fatigue, palpitations, shortness of breath, and chest pain, each of those symptoms were reported by about a quarter of patients as having it happened at any point in the prior 2 weeks, not just at the time of the phone call. Overall, about half of patients reported no symptoms, but half reported at least one within the prior 2 weeks. Next slide. We're looking at cardiac testing that's been done with much less data to date. This is a little bit more intensive to reach out to the providers. But those who had an electrocardiogram, it was normal, about 83%, borderline, about 14. Echocardiogram was usually normal, about 88%. Cardiac MRI was not done much, only 15 so far that we have results for. 2/3 were normal, a third of those abnormal. Again, but we don't know whether this is being selectively ordered, whether there's any other concerns prior to the cardiac MRI. So it's certainly not being done for all patients. And the troponin, when it's been checked in the 25 cases, was normal in 96%. Next slide. So when the cardiologists or other healthcare providers were asked, though, in their opinion, and based on their evaluation thus far, did they think that the patient was fully or probably recovered? About 91% said yes. So 74% said yes, I think this patient has fully recovered by now. And 17% said, I think they probably recovered, but we're waiting additional information, such as further testing with rhythm monitoring and MRI. Next slide. So thank you very much. I'd like to acknowledge the help of a lot of people who contributed to this study and a lot of the projects that are going on, especially Tom Shumakor and John Su, who shared some slides, and Nikki Klein from Vaccine Safety Data Link, as well as Sam Butler from EPIC, Matt Hall and Carrie Thurman from Children's Hospital Association for sharing some of their data. Thank you, and be happy to answer any questions.
Thank you, Dr. Oster, for that presentation. We really appreciate you providing your expertise and sharing it with the committee. This presentation is now open for questions. And as we're waiting, I did have one question for you, Dr. Oster, which is, we recognize that myocarditis in general seems to be more common in males and females at baseline, and also, as we've seen with vaccination. Have you noticed any differences in severity or like distinguishing features in terms of the phenotype and the outcomes between males and females, or is that something you might study going forward?
Yeah, certainly something worth looking at. We haven't really noticed a big difference. One thing I'll mention, I showed those slides earlier with the overall just epidemiology of classic myocarditis, and I failed to mention that what we're seeing so far with the vaccine-related myocarditis does seem very similar to that in terms of peaking in adolescents, not as high in the older population. If the post-vaccine side effects follow for what we've seen for classic myocarditis in the younger age group, we don't expect it to be as prevalent in the adolescents. But yes, for males and females, we will be following it for all ages for sure.
Thank you. Dr. Paling.
Yes, thank you, Dr. Oster, for this great presentation and education about myocarditis of all your different types. One of the questions that I have for you is we have been seeing disparities by race and ethnicity in hospitalization. And I wanted to ask about the COVID-related myocarditis. Are you seeing disparities? And what have you been seeing? Thank you.
Yes, so by COVID-related, if you mean, so the COVID infection-related myocarditis, again, at least in the younger population, we don't see a lot of that with hospitalizations, or at least some. With the MIS-C myocarditis, as we know for MIS-C in general, it's definitely higher in African Americans. That's not fully explainable by their baseline COVID infection rates. Higher in Hispanics, that is partially explained by their baseline COVID infection rates in the population. And for the others, not enough data to really make strong determinations. For the myocarditis after vaccination, I can say that most of the cases for which we know the race and ethnicity, it does actually tend to be more often white, but with two caveats to that. Number one, that data is not always well listed on the VAERS report form. There's an option to report that, but it's often missing or not reported or unknown by the reporter. And second, we have not been able to really look at, the percentages compared to just the underlying vaccination rates. Because certainly if there is, disparities in just the number who are getting vaccinated, it's hard then to interpret necessarily the disparities in the number having the vaccine adverse events. But it's definitely something we're considering and want to look and learn about more.
Thank you. Dr. Brooks?
Yes, thank you. An excellent presentation. Dr. Oster, a couple of quick questions. Was there an increased incidence in myocarditis in those under 30, I guess in the VAERS reporting, with underlying cardiac disease. And I kind of think of that more either electrophysiologic or structural, like CCHD.
Yeah, so excellent question. So we do ask, for comorbidities and underlying diseases. We have not seen any strong patterns in that yet to really, say much about that yet. We've certainly not seen any major upticks or anything jumping out at us yet. We need to try to collect data a little bit more rigorously in that, but in the ones we've been able to reach and do full investigations on, and there are, some limitations to that when we're reaching out to the providers and to the families, we really haven't seen anything of that nature popping up.
And Dr. Lee, if I may ask a second question.
Please go ahead.
I will note that there was no summary slide on this presentation. The questions that have been coming to me as a member have really focused on myocarditis. I'm really trying to summarize a lot of information that you presented, and it's excellent that you have this much information. So you had 877 cases reported to VAERS of people either less than or equal to or less than 30. That was out of 86 million doses. And out of that, it looks like there were either 9 or 10 deaths, and none of them could be linked directly to myocarditis. After all, when you distill down these 877, is that correct?
Yeah, so of those 877, we could not identify vaccine-related myocarditis as the cause of death in the ones that have been fully evaluated thus far.
And I think that's really important as it relates to a lot of the questions and the comments that have been generally given to a lot of us. Thank you. I probably have another question coming back, but that's it for right now, Dr. Lee. Thank you.
Thank you, Dr. Brooks, and thank you for summarizing and clarifying that for all of us. I think that was really helpful. Dr. Hoag?
Yes, thank you. My question is very similar to Dr. Brooks, but with a finer point. Dr. Oster, thanks for your wonderful presentation. What data, if any, do we have about the risk of myocarditis in individuals who specifically have congenital heart defects? Or I know this is an issue that I believe some parents, so we're not talking about a large number of parents here, but some parents are concerned about whose child may have been born with a heart defect, that they're concerned about whether their child's going to have some increased risk of myocarditis resulting from getting vaccinated with the Pfizer vaccine. And I know there's so much we don't know about kids at this point from the study. So I'm wondering if you can opine on anything you have on congenital cardiac abnormalities in the adolescent group.
Certainly. So yes, I'm a practicing pediatric cardiologist, so I get this question all the time. And I participate in some other studies just looking at the congenital heart disease groups in general and how they have been affected by COVID. And so what I can tell you is two things. One, we have not seen an increased risk for myocarditis in those with congenital heart disease, either through my work with CDC or through taking care of these patients. Number two, I can tell you though that there are some data. One study's been published, another that's going through its channels that I know of there, that of kids with congenital heart disease who have severe COVID, meaning they need to be hospitalized for it. Once they're hospitalized, they're more likely to have kind of those critical outcomes, requiring ICU level support or more. So my advice to the number of families that call asking about that, I tell them that I am much more worried about what would happen to their child if they got COVID, for a patient with congenital heart disease than I am if they were to get this vaccine.
Thank you. And we're going to go back to Dr. Sanchez, and then we'll go to Dr. Duchin next.
Thank you, Dr. Oster. I think, and actually your previous comment was extremely helpful as well. But I just wanted to go back with what Dr. Brooks had commented on with the deaths. I just want to clarify, because I think it is really critical and important in terms of the deaths in persons. I think there's slide number 5, aged less than 30 with possible concern for myocarditis. So of those who were reported deaths associated with myocarditis, just want to clarify this. So cases with concern for myocarditis, of the 3 whom it was decided that they did have it, what were the potential? So none of them, so all of them had another etiology and potential infectious cause identified. Do you know what those were? Or
Yeah, so there were, I don't want to get into the details of any individual case for patient confidentiality reasons, and I'm not sure whether these are coordinated by the states and they are responsible for contacting the family. But I will say that those infectious causes, had been both viral and bacterial that had been found, and viruses and bacteria that are known to, be associated with potential myocarditis. So I can share that now, and this is part of the reason why having these full investigations, though, is so important, especially in these cases of mortality, to really look for other things. There still is the background rate of myocarditis that is out there, and what we've seen so far is the background rate of myocarditis can have, we know that it has very significant morbidity and mortality, and we don't think that this vaccine-associated myocarditis has nearly those same acute outcomes.
Just to reiterate that as of now, there has not been a case of myocarditis resulting in death that has been attributed to the vaccine.
That's correct. So there's still stuff ongoing, and we are still constantly trying to see any reports and learn more information if anything comes in. But for those that have the evaluation that has been completed, we've not identified any.
Thank you.
Thank you. We'll go to Dr. Duchin and then Dr. Long.
Thank you, Dr. Lee, and thank you, Dr. Oster, for your ongoing scrutiny of this adverse event. It's reassuring to see that the rates remain low, between 4 and 7 per 100,000 in the highest risk young males. I just wanted to clarify your conclusions with respect to the relative severity of vaccine-related myocarditis and the classic viral myocarditis. And we previously understood that vaccine-associated appeared to be less severe and the patients recovered more quickly. I just want to confirm with you that that's still your conclusion. And then secondly, very reassuring to see, the epidemiology of myocarditis shows very low cases for viral myocarditis in the 5 to 11-year-old group, and wondering if you can comment on whether there's a pathophysiologic basis to think that vaccine-associated myocarditis will be similarly low. And then finally, wondering if you can comment on the study out of Israel that showed that myocarditis from COVID-19 was approximately 3 times more common than that associated with vaccination. Thank you again for your ongoing help with this issue.
Okay, I apologize if I didn't follow all that, so I'll try to take them in piece by piece. All right, so the first thing, just write down what you asked me. So the first one was the conclusion that not to recover well. That's part of the reason why we're doing the study, to look at the long-term outcomes, to, doing ongoing surveillance to figure out what is, will these, young adolescents, young adults look like down the road. And, we've got some early data. I showed the symptoms data, which showed that at some point in the last 2 weeks, it wasn't that surprising. I think a lot of people, certainly, are more keen, can be more keen and aware to symptoms once they've had a diagnosis of myocarditis. But it was very reassuring to see that when you ask the cardiologists who are evaluating these patients, do you think that they have fully recovered? About over 90% of them said, yeah, I do, at least by the 3-month point. We'll certainly keep following up that and watching that, and we continue to add on to those number of patients and the ones that we do have follow up to continue following them. Second, that 5 to 11 year group, Yes, as I said, so far the epidemiology for this vaccine-related myocarditis, both by age and sex, appears to be following what we have seen for kind of this classic myocarditis. We don't have any reason to suspect that it'll be different once you go to the below 12 range, but it's certainly something we'll keep looking at. There are a number of different pathophysiological mechanisms and rationales for why that is, which I won't go into right now. One of the most common thoughts, though, is that certainly hormones play a role, specifically testosterone, how that can alter, what receptors are present on cardiac myocytes, and that would certainly kind of fit the profile over time by sex and age. But this is an area that we certainly want to learn more. And then third, I think your question was looking at the rates of COVID myocarditis compared to higher rates of vaccine-related myocarditis. So what I would say is that yes, I like to think of it as the risk of having some sort of bad heart involvement is much higher if you get COVID than if you get this vaccine. Whether it be COVID related myocarditis in general, or just COVID cardiac side effects like palpitations or other things, or MISC, which has a strong cardiac component to it. So I think that you can break it down different ways as to what you call a COVID-related illness, but the bottom line is getting COVID, I think, is much riskier to the heart than getting this vaccine, no matter what age or sex you have.
Thank you again for your ongoing careful study of this problem.
Thank you. We'll move on to Dr. Long.
Yes, thank you so much. I know you've heard me say some of this before, Dr. Oster, and I completely agree with all of your assessments. I think of the typical viral or para-infectious myocarditis as the apple. And you and I are least comfortable treating this patient. They don't present usually with chest pain. They usually present with cardio or respiratory symptoms and exercise intolerance, and they get better very slowly and with great difficulty, and sometimes don't get better. So they're the apples. I think the oranges are the coronavirus infection-associated myocarditis. And I think looking at these patients and most of the case reports, that more than half of them are MISC. And MISC is such a different disease than viral typical myocarditis. It's like a stunned myocardium. They have function problems and their heart just doesn't work for a couple of days, and then they usually turn around and they're oranges. I don't say that I know anything about coronavirus associated myocarditis in adults with COVID, but in children, this is, somewhere between worse of what I think is myopericarditis, the vaccine associated, which is better, and viral myocarditis, which is worse. And then so there's an apple and an orange and an avocado. This vaccine associated pericarditis is predominantly parietal pericarditis. They have chest pain. It's worse with movement. And they have much less, although their cardiac MRIs are abnormal, yes, they have maybe edema, maybe myocytes, maybe inflammatory changes, but their function is much more usually normal and they're better. But one thing I want to challenge a little bit for you to think about is the 3 cases that you reported that were vaccine associated, reported to VAERS, that had other causes. I have managed a couple of manuscripts of patients who had myocarditis for other reasons. One was a typical viral type myocarditis who was recovering, who got the vaccine and 2 days later had chest pain and had a recurrence of their myocarditis, their dysfunction, but with a flavor of the pericarditis, the vaccine associated. So I think we'll talk later about what might be clinical considerations of underlying conditions. And then the other one was a young man who 20 days after his first dose of vaccine got typical vaccine-associated mild pericarditis, and then got vaccine again 2 to 3 weeks later and had typical 2 days later mild pericarditis. So you could think that you had typical myocarditis and you could still have vaccine-associated mild pericarditis. So I think it would be hard in VAERS, unless you told us that those vaccine-associated cases where there were three other plausible causes, were they 2 days after vaccine, and were they typical? And if they were, it's possible that they did have underlying typical viral mild pericarditis, which was exacerbated with vaccine. Long questions, comment?
Now, thank you very much for those comments. And it's certainly tough sometimes because, as you know, some of the long, myocarditis, some people, and I think of this classic myocarditis, people can be walking around for weeks or months with myocarditis, and then something pushes them over the edge, whether it be some sort of, infectious stressor or something else. And could the vaccine be the stressor in those cases? Who knows? Without knowing what their baseline looks like, that's going to be a hard question to really answer, but certainly something worth considering and trying to capture when we can.
Thank you. Dr. Shaw.
Great. Thank you, Dr. Lee. Dr. Oster, this is Neerav Shaw from the state of Maine. Thank you so much for your outstanding presentation. The theme of my question has been largely covered by Dr. Long and Dr. Duchin, Dr. Brooks's questions. It's largely about the relative risk of myocarditis associated with vaccine versus myocarditis associated with COVID-19 infection itself. For many parents, I suspect that the issue for decision with respect to vaccinating their 5 to 11-year-old children will be this one, which is the risk of myocarditis. Very much appreciate the discussion that's unfolded. It will be very helpful for state officials as they are answering questions. My question for you is it possible to further quantify the relative risk reduction or the differences in risk from vaccine-associated myocarditis versus COVID-19 associated? In effect, I'm sort of asking if you could translate what is on your slide 10 into a rate and an incidence and have that on a bar graph alongside what is on your slide 4, which is the risk of vaccine-associated myocarditis, given that came from VAERS data. A simple bar graph demonstrating the relative risk of those two, I think would be extremely helpful from a communications perspective. Not looking for an answer, but would appreciate your perspective. Thank you.
Yes, I think it's always important to think of these as risk benefits, and we're talking about one risk that people are focusing on with the vaccine, and I would just keep in mind that there's a lot of different risks from having COVID, which were talked about in the earlier talk by Dr. Jones. But yes, trying to put these in context for each other, I think, is important. And having taken care of these kids, and Dr. Long has alluded to it as well earlier, that seeing some of these kids who have had COVID and have had those, even just putting numbers isn't always the same. We've had, at my institution, a number of kids who've been on ECMO just from MISC, and it can be pretty severe. Fortunately, they do get better, but it can be scary. So just the numbers themselves don't always tell the full picture.
Thank you, Dr. Oster. One last question for you, actually. So I guess it seems to me that there's an underlying, perhaps, individual predisposition to developing myocarditis through some trigger. Is it possible that we're just looking at what's underlying in terms of baseline rate, and should an individual who developed myocarditis after vaccination instead were to get COVID infection, it turns out that they might have significantly worse disease. So I guess my question really is, and it gets back to what everyone has been saying, sort of the risk is there, regardless of whatever the trigger is. And it seems like the severity of disease is much worse with COVID-19 associated infection and or honestly like other viral myocarditis cases that we've seen. Is that sort of your understanding of how we should think about the risk here?
Yeah, I mean, there's certainly some factors that may make certain people higher risk than others, and we don't really know all of those, or whether it's the same ones that make them, at risk for classic myocarditis versus, this vaccine myocarditis. Unclear, but the epi so far seems to go that way, but we certainly need to, to learn more, and for everyone trying to understand, what is their, personal risk of having bad outcomes from either. If the same person were to get severe COVID versus get the vaccine, whether those risks are the same or different, sometimes hard to tell, but I think those are important considerations.
Thank you. And I see Ms. McNally, you've raised your hand. Please go ahead.
Thank you. Dr. Oster, my name is Veronica McNally, and I am the consumer representative. I have just a couple questions for you. So first, can you talk about the current management approach of myocarditis in the adolescent age group?
Yeah, so the primary management is starting off symptom-based, meaning that we look and see how is this person presenting. Certainly if someone's having pain, so chest pain is a prominent feature, treating with pain medicine is going to be first line. And so for many of the kids with the vaccine-related myocarditis, all they've gotten is NSAIDs, like ibuprofen. If there are cardiac problems such as poor heart function or other cardiac manifestations, again, which we have not seen much of in the vaccine-related myocarditis kids, more in kind of the classic ones, then you start thinking about cardiac medications, whether that be diuretics or rhythm monitoring agents or other things like that. And then if people are really critically ill, then stepping up and instituting critical measures as needed, which we really haven't seen a whole lot of in the vaccine-associated myocarditis, but is certainly a common feature in many cases of kind of the classic myocarditis. So, it's a lot, as I said, just supportive care at the main stage for treatment. And then in certain cases, some people may do some other inflammatories besides just the NSAIDs, but that's not always common.
Can you just briefly touch on whether or not imaging is a part of the workup through these cases?
Yeah, so for the workup, so part number one is looking for different cardiac manifestations. So EKG and echo are very common. And then some of the, looking for biomarkers, specifically troponin and often BNP. Those are often standard in cases where myocarditis is suspected as a big concern. For the MRI, that sometimes can be institution dependent. Some places will do that too if they're unsure of the diagnosis or if they want to use it for monitoring purposes, either in the acute phase or in the long-term phase, just to look for evidence of any inflammation in the heart.
Okay, and recognizing that the clinical trial did not reveal any myocarditis in this age group, is it believed to be less likely for kids age 5 to 11 to develop myocarditis? Vaccine-related myocarditis.
So let me answer that a certain way. I believe it's less likely that the 5 to 11-year-olds will have, myocarditis, although we will watch and see for sure. And they may have some, but I don't think it's going to be nearly to the extent of the older adolescents and young adults. But I believe that based on the epidemiology that we have seen so far of this vaccine-associated myocarditis compared to pre-COVID myocarditis. I don't think that the pediatric trials were powered enough to really see this because, if we're talking about something that even in the, highest risk groups that we've seen occurs in about 1 out of every 10 to 20,000 individuals, then having 3,000, it's not enough to actually see it. So I don't base my expectations on the vaccine trials. I base that based on the general epidemiology of what we've seen for classic myocarditis and what we've seen for the vaccine-associated myocarditis.
Okay, and in your professional opinion, and to a reasonable degree of medical certainty, with the information you have today, does the benefits of vaccination in this age group outweigh the potential risk of vaccine-related myocarditis?
In my opinion, yes.
Thank you.
Thank you. Dr. Brooks, you get the last question, and then we'll move on.
Oh, thank you. So if you could go back to the slide, it's numbered slide 4. It has your the VAERS reporting for 1 million. No, it's the one that has the orange and the non-orange.
I think it's slide 3. Yep.
So again, this is the pivotal slide for me. So first of all, I think a point is that when we make have this discussion about myocarditis, it's almost relevant only in males. Now we see these 3 female age groups of 12 to, if you will, 24. But first of all, I just want to make that as a comment. But the other question I have, I've been looking through these slides and I'm trying to get clear what the background rate is. This slide has some information per 100,000 annual, then there's the 7-day risk. So when a parent asks me, what's the chance of my child, my 16-year-old, well, let's say no, 12-year-old, 11-year-old child getting myocarditis from the vaccine? I want to be clear on what the background is, and I'll figure it out from there in terms of the increased incidence.
Yeah. So we have there at the bottom of that slide that per 1 million person years, and 1 million people in a 7-day risk. And this can vary a little bit by age, but it makes the slides too busy. But at the higher end, about 1.9. That's 1.9 per million at the baseline. Those that are shaded, those you see, are well above that background risk, especially in the adolescent young males, as you mentioned. For what that overall risk is, though, so that's kind of the 1 in 10 to 20,000 per vaccine. If you're just trying to put this in relative terms, for someone who's wondering about the chance specifically, for their individual child.
Right. Thank you.
Thank you. And with that, we will thank Dr. Oster for his presentation and move on to Dr. Tom Shimabukuro, who will present on vaccine safety surveillance efforts in children. So now we will be looking ahead. Dr. Shimabukuro.
Thank you, Dr. Lee. Today I'll be discussing vaccine safety monitoring with focus on children. Next slide. So I'll be covering at a fairly high level CDC surveillance systems and processes for monitoring vaccine safety in children. And I'll be briefly mentioning systems from the FDA, the Indian Health Service, and the Department of Defense. And then I'll also briefly describe the role of the Vaccine Safety Technical Work Group, or the VAST. I'll mention that the VA is also a surveillance partner. However, they don't have children in their population. Therefore, I'm not including the VA monitoring systems in this presentation. Next slide. So COVID-19 vaccines are being administered under the most intensive vaccine safety monitoring effort in history. And below you see CDC's main monitoring programs. And I'll cover those individually in the coming slides. Next slide. I'll start with Vsafe. This is the CDC's smartphone-based active safety monitoring system that was developed for COVID-19. It uses text messaging and secure web-based surveys. It's now available to enroll children and also available for third dose reporting. Next slide. So participants can register themselves. It's a voluntary self-registration process. Themselves or their dependents after dose 1, 2, or 3. Dependents can be added even if the primary smartphone account is not a Vsafe participant. The parent or guardian must create a profile and then add the dependent. The text messaging is directed to the parent or guardian. The Vsafe check-in schedule is the same for all ages. It's once a day, days 0 through 7, and then after that, once a week through 6 weeks, and then at 3, 6, and 12 months, and the schedule restarts after each dose received. And on the right there, you see a simulated screenshot of what it looks like when you're in there and you're going through the process of adding a dependent. Next slide. As far as the analytic plan, Vsafe will aggregate data from health surveys completed on days 0 to 7 after vaccination for children aged 5 to 11 years. We'll describe the data based on demographics and also describe local and systemic reactions and health impacts by dose received. We'll compare the reactogenicity profile of children aged 5 to 11 years to adolescents aged 12 to 17 years. Reports to VAERS solicited by active telephone follow-up of Vsafe participants are included in VAERS analyses. Next slide. Now I'll cover the vaccine adverse event reporting system, which is a jointly operated spontaneous reporting or passive surveillance system operated by CDC and FDA. Next slide. VAERS accepts reports from anyone, regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. Its key strengths are it can rapidly detect potential safety problems and can detect rare adverse events. As a passive surveillance system, the limitations are inconsistent quality and completeness of information, reporting biases, and the main limitation, generally we cannot determine causality or cause and effect from VAERS data alone. Next slide. So these are the VAERS pre-specified adverse events of special interest as of October 27th. The assessment of these adverse events of special interest includes a clinician review of the VAERS report, follow-up to obtain and review medical records, application of case definitions, and adjudication to classify the report with respect to the case definition. Next slide. We will be specifically focusing on myocarditis and pericarditis in this age group. Potential reports are identified through a Mrna standardized code search that assigns a report that indicates a report could be a potential myocarditis or pericarditis case. Clinical abstraction includes review of the initial report, outreach to the healthcare provider involved in the reported patient's care, request and review of medical records, and will compare abstracted data elements against the CDC case definitions for myocarditis and pericarditis. Next slide. So moving on to the Vaccine Safety Data Link, which is an EHR-based system that includes 9 participating integrated healthcare organizations with data on over 12 million persons per year. Next slide. The VSD conducts rapid cycle analysis. The aims are to monitor the safety of COVID-19 vaccines weekly using pre-specified outcomes of interest and to describe the uptake of COVID-19 vaccines over time. Surveillance in the VSD began in December 2020. Next slide. This is a reference slide which shows the pre-specified VSD rapid cycle analysis surveillance outcomes, the settings in which we're monitoring, the risk window, and exclusion criteria. Next slide. So as far as the VSD analytics strategy, statistical analysis will be similar to what's being done for other age groups, but will include stratified analyses on 5 to 11-year-olds. For the primary analysis, the number of outcomes observed in a risk interval after vaccination will be compared to the number of expected. The risk interval is 0 to 7 days for myocarditis and pericarditis and seizures, and 1 to 21 days for other outcomes. The expected is derived from vaccinated concurrent comparators who are in a comparison interval that's 22 to 42 days after COVID-19 vaccination. So we use a vaccinated concurrent comparator. We're comparing vaccinated individuals to other vaccinated individuals, looking at cases in the risk interval compared to cases in a comparison interval. Next slide. VSD will continue to review medical records and adjudicate any potential cases of myocarditis and pericarditis identified within 1 to 98 days following any COVID-19 vaccination. In addition, VSD will conduct chart review of all identified cases of Guillain-Barré syndrome, acute disseminated encephalomyelitis, transverse myelitis, anaphylaxis, and cerebral venous sinus thrombosis within 1 to 98 days following any COVID-19 vaccination. And VSD is able to capture information on simultaneous vaccinations. Next slide. The last CDC system I'll cover is the Clinical Immunization Safety Assessment Project, which is a collaboration between CDC and 7 participating medical research centers. Next slide. The Csec COVID-19 vaccine core activities include clinical case reviews and clinical consults on complex cases of vaccine adverse events, technical consultation on clinical guidance and clinical considerations for use of COVID-19 vaccines, contributions to enhance surveillance for adverse events, and clinical research, including in pediatric populations. Next slide. Now I'll mention some of our federal surveillance partners. This includes FDA, which conducts active surveillance, which includes the BEST system, and collaborations with federal partners. Next slide. Our colleagues in the Indian Health Service conduct passive surveillance and vaccine adverse event system reports through a collaboration with CDC. They also have Indian Health Service Safety Tracking and Response System. IHS also does active surveillance, and that's in the Indian Health Service Sentinel Survey. Next slide. Our colleagues in the Department of Defense also monitor DoD VAERS reports through a collaboration with CDC. They have a system known as the Vaccine Adverse Event Clinical System, or VEX, and the DoD Electronic Health Record and Defense Medical Surveillance System. I just want to mention that it was the Department of Defense that detected the initial safety signal for myocarditis through monitoring in their active duty population, and are a key partner in safety monitoring. Next slide. Finally, I want to describe the the Vaccine Safety Technical Work Group, otherwise known as the VAST. The VAST serves as the central hub for technical subject matter expertise from federal agencies conducting post-authorization and post-approval safety monitoring. They meet weekly or bi-weekly to review data on adverse events of special interest. There's shared learning, including all members, federal partners, and subject matter experts. They review, evaluate, and interpret post-authorization safety data and advise the federal agencies on monitoring, analyses, and interpretation of data. There's also independent discussion of findings by the VAST members. As far as VAST plans for the 5 to 11-year-old group, they will review safety in this age group as soon as possible, continue close review of myocarditis data, and provide updates to the ACIP COVID-19 Vaccines Working Group and ACIP on COVID-19 vaccine safety. Next slide. So finally, to wrap up, I want to make a pitch to our healthcare and public health partners and to the public, especially parents and guardians of children, but also folks coming in to get booster doses. We want you to participate in vaccine safety. You can help CDC by getting involved. Your participation does matter. So what can you do? You can report adverse events following vaccination to VAERS, even if you aren't sure if the vaccination caused the adverse event. You can enroll yourself in Vsafe. Healthcare providers, you can encourage your patients to enroll in Vsafe. And parents and guardians, you can enroll your children in Vsafe. Thank you, and that concludes my presentation.
Thank you, Dr. Shimabukuro. Are there any clarifying questions for Dr. Shimabukuro at this time? Dr. Daly.
Yeah, thanks so much for that presentation, Dr. Shimabukuro. This is more of a comment than a question, but I think it's very helpful for us to look forward and hear what's planned for this age group. But I also think it's important to look back and, since December of 2020, these systems have really shown that they have the ability to detect rare adverse events that can happen following vaccination. And then they're designed to assess the situation rapidly. And then the findings are communicated, transparently to the public and the policymaking folks at FDA and CDC. So, while I know that data from these systems have been deliberately misrepresented, which can cause concern and confusion among the public, I think that definitely represents a challenge. But at the same time, I just feel very reassured to know that we have these multiple systems. They're large, they're distinct, and they're going to be constantly evaluating the safety of COVID-19 vaccines, including for new groups such as the age group we're discussing today. So that's a comment that you don't need to respond to unless you want to. Thank you.
Thank you, Dr. Daly. Dr. Paling?
My comment is, first of all, thank you for a fantastic presentation, and thank you for setting up the most intensive vaccine safety monitoring effort we've ever seen. It's very important. I think I wanted to reinforce a point that's quite similar to what Dr. Daly said, and it's highlighting that VAERS is a very important system to identify potential signals, but it cannot determine cause and effect. And I just wanted to give you a chance to talk about why we have so many other systems and how that's actually done. Thank you.
Sure. So VAERS is the nation's early warning system for vaccine safety, and is a spontaneous reporting or passive surveillance system. It is basically open to anyone. We accept reports from anyone, again, regardless of the plausibility of the vaccine causing the adverse event or the seriousness of the event. And we encourage people to report to VAERS. We depend on people to report to VAERS. Maybe it's important just to walk through what is in VAERS, so that the timeline of a VAERS report. An individual gets vaccinated. At some point in the future, an individual experiences an adverse health event, and then there is a decision to report that to VAERS, whether by the patient or the parent or the healthcare provider. Some reports to VAERS may be true adverse reactions. Some reports may be coincidental events and not related to vaccination at all. VAERS is not designed to determine whether a vaccine caused an adverse event. VAERS is designed to detect unusual or unexpected patterns, which may lead us to believe we have a potential safety problem, or lead us to believe we need to look at a potential safety problem. We can do that in VAERS, or we can also go to more robust data systems like the Vaccine Safety Data Link. In the Vaccine Safety Data Link, we use electronic health records and records with demographic information. And in a system like the Vaccine Safety Data Link, we have complete or near complete information on individuals, including vaccination and including encounters with the healthcare system and medical diagnoses. In the VSD, we are able to calculate rates and assess risk. And we also have systems like the Clinical Immunization Safety Assessment Project, which allows us to do deep dives into individual cases. So basically, we have multiple complementary systems which work together to help us rapidly assess the safety of vaccines. The Vsafe system is probably the most responsive system and has been instrumental in characterizing and confirming the basic safety profile of these vaccines. Vsafe is unique, at least to COVID-19. It was stood up just for COVID-19. And then again, I mentioned all the federal partners involved in safety monitoring systems. So it really is multiple agencies, multiple systems that work in different ways that allow us to rapidly assess the safety of these vaccines. And if we do detect potential problems, we can rapidly assess them and communicate that in a transparent way. So thanks for the opportunity to explain that.
Thank you so much, and thank you for the presentation, Dr. Shimabukuro. Just to put a period on the end of that sentence, there have been over 420 million doses administered in the U.S., and so that is an extensive amount of safety data to date. We're going to move over to Dr. Kevin Chatham-Stevens, who will provide a presentation on implementation of COVID-19 vaccine pediatric program. Dr. Chatham-Stevens, the floor is yours.
Great, thanks so much. I really wanted to thank everyone for the opportunity to describe some of our work preparing for the vaccine for 5 to 11-year-old children. Next slide, please. So I'd really just like to start off with some of the high-level implementation goals we've had for the 5 to 11-year-old vaccine program during the past several months. The first goal was really to reach the most and meet families and children where they are as much as possible, enabling access to and availability of vaccine providers where populations are most likely to seek vaccination. Second, we wanted to ensure vaccine access for vulnerable and underserved pediatric populations. The third goal was to minimize any potential delays between FDA authorization of the vaccine and the initial rollout. And finally, the fourth goal was to disseminate timely clinical guidance to jurisdictions and providers. To achieve each of these, we were harnessing the existing robust pediatric vaccination network in the U.S., complementing that network with additional sites, and building on successes and lessons learned from the adult and adolescent vaccine programs. Next slide, please. So now I'll walk through our approach for reaching children through a variety of different clinicians and settings. In that first row, we have pediatricians and other pediatric providers, such as family practice docs and nurse practitioners, caring for patients in a medical home, which is the optimal location for many children to be vaccinated. Clinical settings such as federally qualified health centers, or FQHCs, rural health clinics, health departments, Indian Health Service clinics, among others, can help ensure vaccine equity and broad coverage. We know that not every 5 to 11-year-old has a medical home, so the medical home will be complemented by other vaccine providers. For example, in the second row, pharmacies will be leveraged to administer vaccine to children who may not seek or have access to care in a pediatric practice. In addition, schools can partner with vaccine providers, such as health departments, pediatric clinics, FQHCs, and pharmacies, to host vaccination clinics at school. These school-located vaccination clinics can provide a convenient option for parents and caregivers who may experience challenges taking their child to a clinic. Next slide, please. As announced by the White House recently, as part of several key initiatives, more than 100 children's hospitals will set up vaccination sites. This will be a critical part of efforts to provide vaccine access for children, especially those with underlying medical conditions. To complement all the previous settings, jurisdictions may also use temporary community clinics, leveraging experience with these clinics from the adult and adolescent vaccine programs. Next slide, please. So now we'll dive into a couple slides about how jurisdictions are planning for the 5 to 11-year-old vaccine. In late September, we surveyed jurisdictions to learn more about how they plan to use different types of vaccine providers and settings. 58 jurisdictions responded to this question regarding which providers they planned on using to deliver the vaccine. Please note that these options were not mutually exclusive. As you can see, jurisdictions seem to be using an all-of-the-above approach, with most jurisdictions planning on using large pediatric providers, VFC providers, pharmacies, temporary community vaccine clinics, and school-located vaccine clinics. Next slide, please. In a follow-up survey, we asked jurisdictions to rank the settings in which they anticipated most 5 to 11-year-olds would be vaccinated. Here we're showing the settings that were ranked either number 1 or number 2 by jurisdictions out of 8 different options. Pediatric providers were the most highly ranked, followed by FQHCs and rural health centers, health departments, and pharmacists. Next slide, please. Next, we wanted to show some data from a parental survey conducted by the University of Iowa, RAND, and CDC in late September, early October. Among just over 1,000 parents of children 5 to 11 years old, almost 2/3 felt comfortable having their child vaccinated in their regular doctor's office or clinic, followed by the pharmacy and another doctor's office or clinic. Approximately 1/4 of parents felt comfortable having their child vaccinated at school with the parent present, and about 15% without the parent present. So surveys of both jurisdictions and parents indicate 5 to 11-year-old children will likely be vaccinated across a variety of settings. Next slide, please. And I'll finish up with a couple slides describing some of the support we've provided to jurisdictions. As mentioned previously, we've conducted 2 jurisdictional surveys to help guide outreach and planning and identify key issues. We've also disseminated an operational planning guide and preliminary information about the Pfizer-BioNTech vaccine. The operational planning guide included some key information about the vaccine, assumptions to inform planning, and strategies for jurisdictions to consider implementing. For example, a checklist in the document included various tasks such as jurisdictions routinely evaluating the adequacy of the provider network, identifying gaps and whether additional vaccination locations, such as FQHCs, pharmacies, school-located vaccination clinics, or rural health clinics, may be needed to further increase equitable access and ensure vaccine equity. This particular planning document is available on the CDC webpage pictured on the right. The document about the Pfizer-BioNTech vaccine included a side-by-side comparison of the adult-adolescent formulation and the formulation of 5 to 11-year-olds. Next slide, please. CDC is also working to provide guidance on and support of school districts partnering with pharmacies to conduct school-located vaccine clinics. Some of our resources for schools are available on the webpage pictured on the right. We've also conducted numerous listening sessions with a variety of public health, clinical, and other partners to hear about potential challenges in the rollout of the vaccine and what resources CDC or others could provide to help facilitate the rollout. And with that, I'll end and just wanted to acknowledge the variety of folks across the agency and out in the jurisdictions who are helping ensure that this vaccine rollout is successful. Thanks so much.
Thank you, Dr. Chatham-Stevens. Since we're running fairly far behind today, I'm just going to ask for clarifying questions related to this presentation only, but we'll ask Dr. Chatham-Stevens if he'd be willing to be available to answer some general implementation questions after we're able to get through the next session. So Dr. Daly.
Yeah, thanks so much for that. I have a question that either if we can address now or down the road a little bit, but just about what the communications plan is, because I am thinking that for many parents, the considerations around myocarditis may be the focal point, and I just want to think ahead about how we communicate that to providers and the public. Thank you.
Sure. Our communications experts have done a fantastic job of laying out a plan to make sure we're communicating to key populations, including parents, obviously, but also our providers, so that they can then amplify the appropriate messages, and then our partners as well, including health departments and academic professional societies as well. So I think it's a matter of some of the key points are that have so eloquently been laid out previously, that COVID-19 does present a risk to children, and that we have to balance that risk and the potential side effects when discussing this particular decision with families. And I know a lot of this information, the communications materials, will be disseminated in the coming days on this topic.
Thank you, Dr. Chatham-Stevens. I don't see any additional hands raised for the moment. Oh, okay, Dr. Paling.
I'm sorry, thank you for this presentation. I wanted to ask about input in this implementation planning, and were people who were historically marginalized populations included in this planning process? Thank you.
Sure. Thanks for that comment. And I know this vaccine equity is definitely top of mind for our jurisdictions, our folks out in state, territorial, local, and tribal health departments, as it is for us here at CDC. And I think this is really our opportunity to build on some of the lessons learned and successes from the adult and adolescent rollout. We have numerous resources online that, including various toolkits that are aimed at various different partners to help ensure that we're engaging in equity work across the vaccine program. And I will say each of the particular settings that I walk through can contribute to this. We know that the VFC program, historically has done a great job of providing vaccine to those children who may not otherwise be able to afford the vaccine. FQHCs, rural health clinics, and tribal health care providers can also help ensure that vaccine is available for their particular populations, as well as school-located vaccine clinics. We know some families, because of transportation challenges or other reasons, can't necessarily make it to a clinic during regular business hours. So making sure that we have pharmacies and school-located vaccine clinics available can help ensure that the vaccine is widely available to various populations.
Thank you so much. Thank you for the excellent presentation. And our committee will recess until 3:15 p.m. So you have 9 minutes for a break, and we'll see you back at 3:15.